Buenas tardes a todos. En nombre de la Sociedad Panamericana de Oncología Ocular, quiero dar la bienvenida a todos ustedes, nuestros amigos, y comentarles de que hoy día tenemos el tercer webinar de la Sociedad Panamericana de Oncología Ocular. Hoy día tenemos el placer de poder contar con dos grandes maestros de la oncología ocular mundial que ya van a ser presentados, y a la vez contamos con dos moderadores de alto prestigio también en la misma especialidad, que son el doctor Rubens Belfort, oncólogo ocular de Sao Paulo, Brasil, médico oncólogo ocular de la clínica Belfort, profesor de oftalmología de la Universidad Federal de Sao Paulo, ex jefe del sector de oncología ocular del Departamento de Oftalmología de la Universidad Federal de Sao Paulo y past president de la Sociedad Panamericana de Oncología Ocular. También tenemos el placer de contar como co-moderadora a la doctora Carolina Alarcón, también oncóloga ocular. Ella es de Cali, Colombia, trabaja en el Centro Médico Imbanaco, en Cali, ex fellow de oncología ocular en el Wilshire Hospital de Filadelfia y es profesora de oftalmología de la Universidad del Valle. Así que, sin más preámbulos, quiero ceder la palabra al doctor Rubens Belfort para que dé inicio a esta importante sesión con estos grandes invitados que hemos convocado el día de hoy para las ponencias correspondientes. Bienvenidos a todos.
Gracias, Solón. Bueno, empiezo a hablar inglés para que Carol y Ratem me puedan comprender. Thank you, Solon. I'll switch to English for our American colleagues to not to be tortured by my horrible Spanish. And first of all, I want to thank Solon and Melina and the new team of the Pan American Ocular Oncology Society. As all of you know, Dr. Shields has been fundamental keeping the society going, and she was supportive as Solon as the new president. And I think we're very proud because we haven't seen this much action in the past 2 years. And now a lot of seminars going on, education activities, and that's very important for Latin America. And I think it's very important to have the superstars, Dr. Carol Shields with us, but Solon has also been able to promote Latin American doctors giving lectures as well, and that is fundamental. Dr. Shields and Dr. Hatem, as you know, our system in Latin America is completely different from the American system. So we do need evidence-based medicine, but we need a bit of a twist to make it work in Latin America, because sometimes not only the cost, but the culture are different. So it's very good to have American and European professors giving lectures, but it's also very, very important to have local physicians that see the adequate number of patients and treat ocular oncology patients to give their experience and share their experience as well. So it's my pleasure and honor to introduce Dr. Carol Shields. Everyone in ophthalmology has heard of both Carol and Jerry. As you know, Dr. Shields is the chief of the Ocular Oncology Service at the Wills Eye Hospital and professor of the Thomas Jefferson University in Philadelphia. And Dr. Shields has authored more than 12 books, 1,400 papers in major journals, and over 300 textbook chapters. So far, more than 700 lectures. I think that was before coronavirus, right, Carol? I'm sure you've given more than 1,000 lectures by now. And not only she's the expert, leading expert in ocular oncology, but she's an amazing teacher. People say, you know, if they practice enough, someday maybe they'll be able to present like Carol Shields does. So it's very important to have you here. And also our good friend from Canada, Harem Krema. I believe Hatem was a fellow with Dr. Shields years ago. Professor Krema is the director of ocular oncology at Prince Margaret Cancer Hospital in Toronto. He's been very active in presenting and participating in international meetings, author of several articles in ocular oncology and peer-reviewed scientific journals. And something very important. The Canadian system in many ways is similar to the systems we have in Latin America. So being ahead at Prince Margaret, he sees most of the ocular cancers from that part of Canada. So it's very important to have you both here with us. And without further ado, I'd like to invite Dr. Shields to share her screen and start her first presentation.
Did it?
Perfect. Yes. Thank you so much.
Okay. So we're going to talk about choroidal nevus growth into melanoma using multimodal imaging in 3,800 cases. So if you look at this small pigmented choroidal lesion, that looks like a juxtapapillary nevus, right? But does this bother you, orange pigment? And does this bother you, this puddle of subretinal fluid? Maybe not so evident clinically, but if you get autofluorescence, you can see the orange pigment and the subretinal fluid as hyperautofluorescence. And if you get OCT, you can see the trace fluid in the papillomacular bundle, and on a vertical cut, you can see the fluid, you can see the fluid in the region of the mass. I think this lesion is really not just a nevus. It has features of risk factors for possible activity, and this is probably an active melanoma. In fact, if we look back to 2009 and compare it to 2014, this lesion has unequivocally enlarged and developed more features suggestive of an early melanoma. Multimodal imaging of choroidal nevus can allow us to identify high-risk features. So when we looked at choroidal nevi or choroidal tumors in general, we do a lot of imaging. For example, when we see new patients with an intraocular tumor, we will always get photography, and I will talk about the special camera that we really like to use. We'll get ultrasound and fluorescein, OCT angiography, and autofluorescence. And when we evaluate our follow-up patients, we generally don't do fluorescein unless it's absolutely necessary. We usually save ICG only for those tumors that we think might be hemangioma, or if we think we have polypoidal choroidal vasculopathy. And we generally save MRI for retinoblastoma or really high-risk tumors that may have invaded outside the eye, or if we can't see the details inside the eye and there's vitreous hemorrhage, we'll get an MRI with gadolinium to see if there's enhancement within the eye suggestive of a vascular mass. Now, just one word about wide-field imaging. I have no financial interest in Zeiss imaging, but we use the Claris camera. It's one image, non-midriatic, but we always dilate. It's true color, and many of these wide-angle cameras have artificial color. And those of us, all of you, we're all ocular oncologists, and part of the way we judge a lesion is we want to know the color of the lesion. If it's orange, we think of hemangioma. If it's brown, we might think of a melanocytic tumor. This is a seamless imaging, 130-degree imaging expanse, and you can merge them into over 200-degree size images. So we like to use that imaging. Now, does imaging help with identifying choroidal nevus with risk factors for growth to melanoma? Well, in the past, we judged choroidal nevus risk factors using clinical judgment. I, the doctor, would say, I think this is suspicious, or I think I see orange pigment, or maybe there's a little fluid. But now we don't do it that way. Now we use imaging to confirm what we clinically suspect. So in the old days, we used clinical factors based on doctor judgment. For example, we look at this pigmented lesion in a patient with macular degeneration, and we say, well, what is the risk for this to transform into melanoma, that lesion there? Well, it's probably low. I'm not really sure what the risk is, but I will get into how we can give exact estimates of risk, because now we use imaging factors. So we looked at 3,800 patients who were imaged looking at factors that predict nevus transformation into melanoma. So I'm going to ask you 4 questions. Question number 1, does imaging help with identifying choroidal nevus with risk factors for growth to melanoma? And the answer is yes. Number 2, are outcomes different based on various combinations of risk factors? And the answer is absolutely. Number 3, does choroidal nevus thickness matter? And the answer is yes, it does matter. And number 4, is the rate of nevus transformation the same or different based on your race? And the answer is it's the same. And we wrote 4 papers on each of these topics. These 4 papers are highlighted here. They were published in Retina, British Journal of Ophthalmology, Retina again, and Indian Journal of Ophthalmology. And I'll just briefly go through each of these 4 publications, looking at imaging and how it helps us judging choroidal nevus transformation into melanoma. So question 1, does imaging help with identifying risk factors for nevus growth to melanoma? Well, this article published in Retina 2019 was the 2020 Taylor Smith and Victor Curtin lecture that we gave in Aspen. It was actually the last meeting I attended. It was in February 2020, and shortly thereafter, we were in shutdown because of coronavirus. But we took 3,800 cases and studied transformation of nevus into melanoma based on imaging in every single case. And then we calculated risk factors. So if you look at all 3,800 patients, transformation into melanoma is uncommon. Only 1% of patients show transformation at 1 year, 6% at 5 years, and 14% at 10 years. And let me explain. These are patients sent to an ocular oncology center, so they're the riskiest lesions out there. Retina doctors, ophthalmologists are really worried about these lesions. By 10 years, only 14% converted. And we found by using statistical analysis that there were 6 risk factors: thickness over 2 millimeters, fluid subretinal, symptoms of vision loss, orange pigment, hollowness in ultrasound, and diameter more than 5 millimeters. And we remember these by the letters TFSOM, dim. And if you can't remember that, I remember it by this top part, 2 fine small ocular melanoma doing imaging. That allows us to remember these letters in order. And the imaging includes ultrasound for thickness, OCT for fluid, Snellen acuity for vision, autofluorescence for orange pigment, ultrasonography for melanoma hollow, and photography to judge diameter greater than 5 millimeters. Each one of these was highly significant. And if you look at the most important factor, that was thickness over 2 millimeters with a hazard ratio of 3.8. What does that mean? That means if a patient has a lesion over 2 millimeters in thickness, they have a 3.8 times greater risk for growth into melanoma by 5 years compared to a patient with a lesion under 2 millimeters in thickness or under. And another really important risk factor was subretinal fluid and orange pigment. I call these the big 3: thickness, fluid, orange pigment. Now, if we look at these 6 factors, any patient who had 1 factor had an 11 times risk for growth by 5 years, 2 factors a 22% risk, 3 factors a 34% risk, and right here is the break point. 4 factors or more, you have a greater than 50% chance for growth. So these are risks for growth by 5 years using Kaplan-Meier. And the hazard ratios accumulate with a greater number of factors that one might have. So let's put our new mnemonic to work and score these lesions. And these are all under 2 millimeters in thickness. Remember, I said over 2 millimeters is a risk factor. So this patient has a pigmented juxtapapillary choroidal lesion, thickness only 1.4 millimeters, base is 4 millimeters, but there's subretinal fluid on OCT. There's orange pigment on autofluorescence, but we can't even see the lesion on ultrasound. If we look at our 6 risk factors, this patient has a score of 3 risk factors. 3 risk factors impart a 5-year risk for growth of 34%. This is a very suspicious lesion. Here's another one, base of 5.5 millimeters, thickness of 1.8 millimeters, obvious subretinal fluid on OCT, very bright hyperautofluorescence on autofluorescence, orange pigment, implying orange pigment, and it's a little bit hollow on the ultrasound. If we score this lesion, there are 5 of 6 risk factors. This is a 30-year-old man with this picture. This patient has greater than 50% chance this lesion will be bigger in 5 years. This is one that we would treat promptly. Generally, if someone has 4 or more of these risk factors, we intervene promptly. So here you can see that gentleman, the 30-year-old man, with this pocket of orange pigment before and then after treatment. The orange pigment and the subretinal fluid resolves and the tumor involutes. Now back to that 90-year-old gentleman. Remember I said, we would guess back in the clinical days when we used clinical risk factors, the doctor would guess if it's high or low risk. This lesion didn't look so high risk to me. It was only 4 millimeters in base and 1.2 millimeters in thickness. And when we score it, it only had 2 risk factors, fluid and orange pigment. But a few years later, he came back, and no doubt this tumor had grown into an epipapillary choroidal melanoma that needed treatment in this 90-year-old man. Risk factors are very important. He had a 22% 5-year rate for growth. Okay, question 2, and we'll answer these questions quickly. Are outcomes different based on various combinations of risk factors? I'd like to highlight this article because this was an excellent article published in British Journal of Ophthalmology by Lauren Dalvin and her team, our team from Wills Eye Hospital. We looked at combination of multimodal imaging features predictive of choroidal nevus transformation into melanoma. Now, don't get scared when you see this really long table, but it goes through individual Kaplan-Meier 5-year rate of growth based on no factors. Only 1% grew in 5 years. Based on 1 factor, 11% growth. 2 factors, 22% growth. And each individual combination of 2 factors gave a different rate of growth. 3 factors, 34% rate of growth. 4 factors, over 50% rate of growth, and the same with 5 factors. We had no patients with 6 risk factors, only up to 5 risk factors. There were 63 potential combinations of risk factors in this analysis. And then we constructed this heat map where red columns and orange columns indicate high rate of growth, some up to even 100% rate of growth. And then blue and green indicated low rate of growth, under 50% rate of growth. And you can see some of these real high rate of growth, thickness over 2 millimeters, orange pigment, and diameter greater than 5 millimeters. I think this report by Lauren Dalvin, who's currently the chief of ocular oncology at Mayo Clinic, is an enormously resourceful report that you can actually look at a patient and say, you know what? You have a 61% chance for growth by 5 years based on this data. And we use this quite a lot. So if we look at nevus versus melanoma, you can see this patient from Australia had a small nevus in the temporal macular region. A few years later, it was bigger with orange pigment and subretinal fluid. You do the imaging, you see the orange pigment as hyperautofluorescence and the subretinal fluid as a pocket of fluid inferiorly, and you can confirm that on OCT. So we always use multimodal imaging in judging risk factors. This patient had 4 risk factors with a 17 times relative risk for growth. We said this was a melanoma, and we instituted prompt treatment. Here's another patient who had a very high-risk looking lesion with orange pigment, and it's hard to see, but there was a pocket of fluid. You can see on autofluorescence, it outlines the orange pigment as hyperautofluorescence overlying the lesion, and then it outlines the subretinal fluid in the foveal region with a pseudohypopion of orange pigment, lipofuscin, that gathered in the subretinal fluid. And we can confirm this on OCT. You can see all that orange pigment or debris accumulating in the subretinal fluid. Just based on these images, we were concerned this was a melanoma. There were 5 risk factors, and when you put all the risk factors together, this was enormous, a 595 times relative risk for growth compared to a lesion without these risk factors. Now, this is a great topic. Does choroidal nevus thickness matter? And this topic paralleled a study that was done in Belgium by Patrick de Potter years ago. We published this in the journal Retina. Choroidal nevus transformation into melanoma per millimeter increment. So we said, what is the 5-year rate of growth if you look just at nevi 1 millimeter or less in thickness? And it was low. It was less than 1 millimeter, 1% at 5 years. So those really flat lesions hardly show growth. But as a nevus gets thicker, 1 to 2 millimeters, the rate increases. The 5-year rate for a 1 to 2 millimeter nevus was 2%. Look what happens at 2 to 3 millimeters in thickness. It escalates, and pretty dramatically, up to 25%. So this greater than 2 millimeter is our most important risk factor. It's actually a cutoff where the risk sharply escalates for nevus transformation into melanoma. And then lastly, is the rate of nevus transformation the same or different based on race? We published this in the Indian Journal of Ophthalmology. Charlotte Morris did the work with our team, looking at malignant transformation of nevus according to race in 3,334 consecutive patients. Basically, we found in this cohort, most patients, 95% were Caucasians, and by comparison, Caucasian versus non-Caucasian, there were some differences. For example, Caucasians were a little bit older, 61 years versus 56 years. Caucasians were more likely female, more likely with dysplastic nevus syndrome, and more likely with previous skin melanoma. But if you look at a comparison of the outcome of nevus transformation into melanoma, there was no difference. 2% for Caucasians, 3% for non-Caucasians, p-value non-significant. So in this analysis, there was no difference per race in nevus transformation into melanoma. And this is important because with skin melanoma, it's well established that non-Caucasians do worse because of late detection. Not only does the patient deny it's a melanoma, but the doctors do. They say, it can't be a melanoma. Only Caucasians get melanoma. But in contradistinction to that, non-Caucasians can get skin and uveal melanoma. We looked at prognosis of uveal melanoma based on patients' race in 8,000 patients and published this in Eye, 2015. Most of our patients, 98% were Caucasian, and 1% were Hispanic, Asian, or African American. And we found that Caucasians generally were older with choroidal melanoma, and they had tumors that were further from the foveola and greater and less thickness compared to non-Caucasians. But if you look at the rate of metastasis at 5 and 10 years, the p-value was non-significant. For Caucasians, it was 15 and 25% rate of metastasis at 5 and 10 years. Hispanic, it was 13% for each. Asian, 4% and 36%. And African Americans, 8% for each. And this was non-significant. So if you had this lesion in your eye, would you want your doctor to say, this looks like a nevus and it carries a little risk for melanoma, or would you want your doctor to say, this looks like a nevus, there's 3 risk factors, so there's a 34% chance this could grow into melanoma over 5 years? I think I would like the latter because I'd like to know exactly what my risks are. So remember the mnemonic: to find small ocular melanoma, doing imaging, where the T stands for thickness over 2 millimeters, F for fluid, S for symptoms of vision under 20/40, O for orange pigment, M for melanoma hollow, DIM for diameter greater than 5 millimeters. There are only 6 risk factors, And if you remember this mnemonic to find small ocular melanoma doing imaging, you can remember all of these risk factors and identify melanoma at a very early stage using ultrasound, OCT, Snellen visual acuity, autofluorescence, and photography. Thank you.
Very good, Dr. Shields. Thank you so much. And I think we're gonna save the questions for the end, right, Solon? So we're gonna invite Dr. Harem Krema. Harem is here.
So can you hear me?
Yes. It's good to see that
My talk tonight will be about radiotherapy of uveal melanoma. So as you all know, COMS trial about 30 years ago and other centers around the world found that there's no statistically significant difference between enucleation and using radiotherapy to treat medium-sized melanoma. And that represents a big category from 2 millimeter up to 10 millimeter height. And since then, it became the standard of care for treatment because you can preserve the eye and maybe some vision after treatment instead of going straight to enucleation. So what are the sources of radiation we know that we use medically? So radiotherapy sources come either through nuclear decay. So you have a naturally radioactive material that loses some energy, some atomic particles, subatomic particles, and change to a new element, or it's rendered radioactive. And that's what we use when we use radioactive plugs or gamma knife. Or we use subatomic particles that we accelerate them so they gain energy, and we use them to bombard tumor tissue. So that's the mechanism in proton beam and linear accelerator photon radiotherapy. It's important to know that the biological effects of radiation vary, depends on the type of radiation. What you get from the same energy with photons differs its effect on the tissues when you use charged particles. The total dose has an impact, the dose rate, how much you give per unit time, and the way you divide your energy over sessions. That's the fractionation scheme. So in brief, the radiation techniques we use to treat melanoma is either brachytherapy or teletherapy. Starting with brachytherapy, here the radioactive source is adjacent to the target volume. So the radiation just covers the tumor, maybe a little bit of tissue around it. So it provides the most conformal radiation dose distribution than external beam. And subsequently, it causes the least collateral radiation toxicity. So when we talk brachytherapy for melanoma, we're talking about episcleral plaque radiotherapy. And the commonest isotopes used are iodine and ruthenium, and maybe a center in the New York use palladium. We're less likely to use the others like iridium, cobalt, or gold. There are other indications for brachytherapy in ophthalmology, but that's for a different talk. So iodine plaque, we use iodine-125. This isotope decays to tellurium-125 with emission of gamma rays and some X-ray. The half-life of it is about 60 days. So obviously it would be custom made for each patient. The gamma rays have high energy, so they can penetrate through a tumor apex up to 14 millimeter. You normally treat up to 11, 12 millimeter tumor height, but it can go up to maybe 14 in some studies. The other advantage is that it has a customizable radiation field. You can put higher energy seeds to one side of the plaque and lower to the other side, so you can change the shape of your radiation field. And we're going to talk about that in details later. And the seeds are recyclable. The cons is that it's relatively costly because, as we said, it's custom made for each patient. The radiation comes from it out like a fountain, so it gives like a bit of wider penumbra in comparison to ruthenium. And the plaque itself is thicker, the COMS plaque has a thick rim of 3 to 4 millimeters, so you might find difficulty sometimes with tight orbits and you try to put a big plaque. that can be a little bit of a challenge. There is the Combs plaques and iPhysics plaques. The difference is that the Combs plaques, the seeds are embedded in a silastic sheet that's glued to the gold, while the iPhysics, the seeds are glued directly to the gold. Theoretically, the penumbra or the side radiation of the iPhysics is less than Combs, but studies have shown that the outcome is almost the same. I think the last one was by Bell Harbor, done 2019. He found no difference in the outcome using this or that. Ruthenium plaque, which is more common in Europe and Asia, Middle East. It's one sheet of that emits ruthenium. That's made of ruthenium-106 that quickly decays to rhodium-106, that decays to palladium-106 and emit beta particles. These beta particles are particles. They are like electrons. They are not rays like what we've seen in iodine. So they can face resistance when they pass through tissues. The half-life is long. It's about a year and some days. And the advantage of it, it's a nice thin plaque. As you can see, I worked with that. You can slide it under one of the muscles. You don't need to detach the muscles every time you work with it. It's reusable and economic to start with. And it doesn't hit sidewise as much as with iodine. However, because there is resistance for those beta particles to penetrate through tumors, it cannot penetrate in tumors higher than 6 millimeter, and some people say 7 millimeter, and they use it for that. The other thing is that the radiation comes from the field is uniform. You cannot make it hotter on one side of the plaque than the other. And it has a very high scleral dose, so might be more ideal for epibulbar tumors. This table quickly summarizes the differences between the main three isotopes. Just want to show you here that the dose, the difference, the sclera to apex dose is 8 times in ruthenium than that in iodine or palladium. So it's very hot on the surface, and the likelihood to get some scleral necrosis down the road in some of those patients is higher with ruthenium than the others. The collateral radiation, as I mentioned, is higher with iodine. And the cost effectiveness is ruthenium because it has a long half-life in comparison to the other two. So that's usually the people what they start with, although that doesn't penetrate much in the tissues in comparison to the other two. So how do we calculate the dose? There is a software called Plaque Dosimetry. There are several software. Most commonly used is Plaque Simulator. There is Pinnacle, there's Monte Carlo. The dosimetry software calculates the virtual dose that you want to deliver to tumor, so you make sure that you cover the entire tumor with adequate dose. We aim at 85 gray to the melanoma apex, and the dose rate should not be less than 50 centigrade per hour. 85 gray is 8,500 centigrade, so if you divide it on the hours of 1 week, it gives you about 50 centigrade per hour. The applications of brachytherapy, not just uveal melanoma, it extends to become the standard of care for most of the intraocular tumors, benign or malignant, unifocal retinoblastoma, and now it has applications on lots of ocular surface cancers. And obviously, because it's a procedure done by the ophthalmologist, it allows you at the same time to take biopsy for cytology or genetic testing. Not on a separate procedure. You do the biopsy, then you submit it to the radiation oncologist to do the external beam radiotherapy. So that's the advantage of brachytherapy. For teletherapy, which is synonymous with external beam radiotherapy, so I'm going to use EBRT when I'm talking about teletherapy. So teletherapy is here, the source is away from the eye. The type of energy can be electromagnetic waves, and that's what we use in gamma rays or the photon irradiation, the LINAC photon irradiation, or charged particles such as proton beam, helium ion, electron beam. So electron beam is not used for melanoma, it's used for surface tumors. Helium ion is kind of obsolete, but proton beam and the other two electromagnetic wave sources are still in use to treat melanomas. When we deliver the teletherapy, the EBRT, it goes through fractionation, like in sessions. The advantage of that is that it permits tumor reperfusion. So that allows oxygen to the water with oxygen to go through the tumor. And with radiation, you create oxygen radicals, which helps you to break the DNA of the tumor. It also recruits more tumor cells into cell cycle. The selectivity of radiotherapy comes that it hits the actively dividing cells. The cells, when they are in mitosis, they are more vulnerable than cells that are stable in G0 in cell cycle when they are exposed to radiation. So the more you have cells, dividing cells, the more the damage, the more cell population damage you get. And it allows repair for normal tissue that receive sublethal radiation dose. That's the tissues around the irradiated area. It allows for the blood to go through and allow for some repair instead of complete charring of those tissues. Now, because the target is away from the radiation source, we have to have some consideration. It's not like the plaque, you just put it on the eye. Now you're gonna repeat the session, the radiation every day for several sessions. You have to make sure that the head is fixed all the time in the same place in every session. You have to put the patient exactly in the same position in the machine in every treatment session. You have to make the eye fixed during the treatment. And we need to focus the energies to hit as much as possible at the tumor without damaging the tissues around. So for head immobilization, there's been several ways to fix the head. One was the relocatable head frame. The patient clenches with his teeth on a mouthpiece, and you wrap his head like this to prevent it from moving. That's usually not very comfortable for elderly patients, and sometimes they have teeth problems, so that's not used commonly anymore. We have the Leskill frame screwed to the skull with gamma knife. That's invented by a Swedish neurosurgeon. It's actually, you fix the head with screws that are pinned to the skull, because you need to fix the head for a long time during gamma knife treatment, usually for brain tumors. So it sounds painful, but usually gamma knife is given on just one session. And what's commonly used in proton beam and external beam using photon therapy, linear accelerator, is the customized face mask. So that's a rigid material that once you put it in warm water, it softens, and you can wrap it around the face of the patient. It takes the shape of the patient, and you fix it with the screws to the bed where the patient is gonna lie, so he cannot move his head around. How can we make sure that the patient is exactly in the same position under the machine at the beginning of each session? So we do an initial CT scan. All those current machines, they have a built-in CT scans that is used first by the radiation oncologist to look at the images to delineate where are the tumor edges. And that initial CT scan is used as a template for subsequent head positioning. So when we take the first initial CT scan, there are laser beams coming from different sides of the room, and we mark where these beams meet at the head, at the face mask, and we make a mark. So every time the patient comes, we put the face mask exactly at the same location where the laser beam meet. And we do that before each session to make sure that we ensure perfect alignment. Third, the eye fixation. So there is several ways. The most common now is to give the patient a fixation target, usually a green light he looks at while the radiation is hitting the other eye, or sometimes it's in the same eye if the patient is monocular. And you use a CCTV camera that the radiation oncologist is watching for any movement during the radiation delivery. Some machines, they have eye tracking system, like what you see with refractive surgery, that if the eye moves, the machine stops. Sometimes we require retrobulbar anesthesia, but this doesn't guarantee complete akinesia. If you want to keep the eye fixed for a long time, such as in gamma ray treatment with the gamma knife, we may need to use a retrobulbar block in addition to brittle sutures of the recti muscles. And children, we normally use suction cup under general anesthesia to fix the eye centrally before we give external beam. And last, we need to make sure that the radiation hits as much as possible towards the tumor without giving high dose to the tissues around. So here came the idea of stereotactic application of radiotherapy. That's dividing the energy beam into multiple beams that converge at a focus at the target. So that provides tumor coverage, and the tissues along the path of these beams receive just a fraction of the total dose. And that's what we apply when we do proton beam or photon radiotherapy, cyber knife, or gamma knife. Now let's talk about the three machines used to treat the uveal melanoma, the teletherapy for uveal melanoma. Proton beam. So proton beam is cyclotron accelerated positively charged particles irradiation. These are protons. The particles, they have a physical property called Bragg peak effect, is that the speed of the particles can be adjusted so when they lower their speed at the target tissue, they can interact with the electrons there and attract them from their orbit and annihilate them without much of proton beam energy left outside the target volume. It also has kinetic energy because they are particles. So that also the speed slow down enough at the target volume so it can hit into the electrons and particles of the atom of the tumor to destroy them without causing much destruction as they fly through the other tissues before they reach the target volume. So subsequently, that gives high delivery, as you can see the Bragg peak, the high delivery of energy at the target volume with less radiation outside what we call small penumbra or sharp lateral penumbra with no exit dose. The melanoma treated with proton beam also would be in 5 fractions, same technique as we described of head immobilization, eye fixation, and so on. It's given at 50 grays in 5 fraction, or in some centers like in France, they give it 60 gray in 4 fractions. Proton beam radiotherapy, as we mentioned, gives superior conformal dose distribution to any other teletherapy modality, though it's still inferior to plaque radiotherapy. I learned from my colleagues who are using proton beam that the energy is not that accurate as imagined, like tumors in the supratemporal part of the eye sometimes burn the lacrimal gland nearby. And also they have high rate of radiation-related complications in comparison to what we would see with brachytherapy. But still, it's superior to other forms of radiation treatment that we're going to talk about, the teletherapy treatment that we're going to talk about. So it's safer treatment for most intraocular, orbital, and adnexal tumors. The other downside is that you have, before you get the patient to treatment, you have to suture radio-opaque markers made of tantalum on the sclera around the perimeter of the tumor. So actually take the patient to surgery, put him to localize where the tumor is, put the sutures, the tantalum clips in the sclera, then you send them to have the proton beam radiotherapy. While in plaque, you can just do that in one session, put the plaque on, and that's the radiation itself. Gamma knife is rarely used in melanoma, but it's commonly used with brain tumor. Here, the patient goes under a helmet that has 192 cobalt sources. Cobalt emits gamma rays, just like iodine. The sources all focus into one focus point, and you can move them by servo drives. The advantage is that it uses MRI for planning, not CT scan, so it's more accurate to identify the tumor within the eye. And the treatment is given in single fraction. However, you need to maintain the eye and the head and the eye completely immobilized for 30 to 45 minutes. And as I say, some centers would go and take sutures through the 4 recti muscles to fix the eye, make sure that it doesn't move for such a long time. The melanoma total dose here we use is 20 to 30 gray. Now, the commonest form of external beam radiotherapy is the LINAC-based photon radiotherapy, and that's each country would have a cancer institute and will have this machine in, because this is the oldest, and that's one the most commonly used. They treat breast cancer, lung cancer, all kind of cancers, head and neck cancers, with this instrument. Like in my institution, we have 15 of those. So the linear accelerator provides high energy photons, so it's electromagnetic waves with high energy, which lose energy along the path of the beam, contrary to what we've mentioned in proton beam, where the energy is delivered at the target tissue. The beam diameter is usually larger than 10 millimeters, so that gives you a clue that it doesn't fit with very small tumors. In the past, they used to give, when we treated melanoma with this machine, we used to give 2 beams, one from the front, divide the energy into 2 beams, one from the front and one from the side of the eye, so that the lens receive half of the dose. Then it evolved to 5 beams coming from 3 dimensions, what we call 3D uniform confocal radiotherapy, and to the current technology, which is fascinating, which is called IMRT. So IMRT stands for intensity modulated radiotherapy. So these are the aperture of the beam that is controlled by a multi-leaf collimator. See these leaves, they move around so they can change the shape of the beam coming out. So by doing that, you can deliver the energy to the target volume and spare an adjacent sensitive structure. The beam is not always round and cross-section. It can be shaped the way you like, depends on where the beam is hitting. And the machine now can revolve the gantry of the linear accelerator, can go around the patient for 360 degrees. And as it moves around, the shape of the beam keeps changing, so it keeps hitting only the target tissue and try to spare the tissues around as possible, so to avoid collateral damage. So it's becoming more precise, and it gives shorter duration of radiation delivery. Another similar way is the CyberKnife, which is also the gantry is use the same thing for megavoltage photon treatment, just as the VMAT, but it's mounted on a robotic arm, and it delivers the radiation through the IMRT, through changing the aperture of the delivery through stop and shoot mode. So this and this machine work by the same type of energy, they just deliver it in different ways. So the linear accelerator-based photon radiotherapy, as I mentioned, is the most available type of teletherapy. Here you do not need scleral clips as proton beam. You do not need to fix the head with the skull pinned frame, because the patient can easily fix on a target for 1 minute or 2 minutes during delivery. And it's becoming more precise with shorter radiation session. However, it's really not designed to treat very small tumor volume as that in the eye. The beam width cannot go down less than 10 millimeter in diameter. And no matter how accurate you are, the 10 millimeter is not always 10 millimeter. Usually it hits a larger area than 10 millimeter, so it causes more collateral injury than we expect, so subsequently more complications. So if I come to finally compare brachytherapy versus teletherapy in treatment of melanoma, they differ essentially in radiation toxicity rates, the conformity to tumor morphology, and some situation EBRT might be a better choice. So radiation toxicity, the mechanisms, as we know, is either by direct radiation-induced cell necrosis of the adjacent tumor tissue. The tissues within the path of the beams can undergo necrosis if they are hit by high energy beams. Second is you have retention of a large volume of tumor necrotic tissue, so that induces intraocular inflammation. Besides, you break the blood-ocular barrier with the radiation, so you allow more of inflammatory cells to go inside, and you create an environment of inflammation. And third is that you cause injuries to the vascular endothelium, which is the most actively dividing cells other than the tumor within the eye. So, and the RPE. So that could produces ischemia in the region that was hit, and that ischemia tends to be progressive over time as the vessels try to fix themselves. So the ischemia extends away from the radiation site. So that creates the radiation retinopathy, which takes a while after the radiation start to show its face and start to see areas of ischemia away from the area that's been irradiated. So our group did a study to compare the brachytherapy versus stereotactic radiotherapy, the EBRT, using the photon radiotherapy. And that was some years ago. We found that both have equal tumor control rates, but the toxicity is significantly higher when we use external beam than when we use plaque radiotherapy. They are matching groups, but they responded completely different. Brachytherapy has much lesser toxicity than EBRT. And also we went for a follow-up study to see the dose reaching each structure inside the eye when we treat with brachytherapy versus with teletherapy. So the dashed line in the curve here represents the dose fall off with brachytherapy. Just outside the plaque, the radiation dose goes exponentially down in comparison to teletherapy, which the dose stays the same, almost the same, the treatment dose, even to 5 and 7 millimeter away from the tumor base. No matter how accurate you are with the machine, still the machine is not designed to treat very small tumor volume. And in the old days of the COMSA study, cases that are within 2 millimeter from the optic nerve were excluded from plaque radiotherapy, and they went straight to external beam radiotherapy. And as I said, we used to see patients losing the eye completely when you look at the initial tumor volume that was treated, because we use the external beam radiotherapy. Nowadays, we use a notched plaque that embraces the optic nerve, and we can see excellent outcomes. Sometimes you add extra TTT to the edge near to the disc to make sure that you covered it entirely well. And we see excellent outcome without vision loss. And for the same tumor volume that was treated before with stereotactic, and the vision ends to no light perception because of the high dose of the external beam hitting the nerve and surrounding structure, you can still maintain almost full vision if you use a deep notched plaque. Second difference is the conformity to tumor morphology. Yeah, I talked to you about IMRT and the change of the shape of the beam, but again, the beam, no matter how you change, it's still wide enough to cause damage significant damage around the tumor. But in iodine plaque, you can play with the seeds. You can put it high energy at one side and lower on other side to serve a purpose. So here, when you have a tumor like 2 to 3 millimeter from the optic disc, and you cannot push further because the meninges of the nerve behind the eye are stopping the plaque from going further, you can achieve your extra 2 millimeter edge by putting higher energy seeds at the posterior edge here. So they push the penumbra, the radiation penumbra, a little bit to the side. And you can do the opposite. If you have a tumor that's just next to the fovea and you don't want to have a high energy radiation delivered to the fovea, you can put lower energy seeds at this side in comparison to the other side of the tumor. Similarly, if you have an oblong tumor, you don't need to put a round plaque to hit all around. You can just put your radiation energy in the central meridian and put less energy at the flanks, so that saves more retina from more damage. And if you have a small tumor in the posterior pole, we know everybody's doing plaques, know that how difficult to suture a small plaque behind the eye. There's no space for the surgeon to do that. So you can actually put a bigger plaque and just put the radiation at the posterior half of the plaque. So you have the eyelets anteriorly, so you can suture them easily, but the radiation is just facing the posterior, at the posterior part of the plaque is just facing the tumor. Iris tumors, if the concavity of a plaque can fit well to the convexity of the cornea and gives more comfort to the patient than the edge of the plaque sitting on the cornea. And you can just put your energy to treat the melanoma where in the plaque opposite to where the tumor is without putting energy all around. So all this flexibility comes when we use iodine plaque. Here are some challenging cases, like you have a tumor that it's ciliary body and spreading all around, like you see seeding all over the surface of the iris, and then you have accumulation of melanoma cells inferiorly. This case used to be doomed for inoculation, but you can, by manipulating the seeds, you can put high energy seeds opposite to the big tumor in the ciliary bodies there, more energy to the accumulation of seeds there, and medium or low energy to the iris part of the tumor. And by doing that, we could save this eye, and after 3 years, the vision is 20/40, and patient kept her eye after a cataract surgery. Similarly, if you have a large tumor like this, straightforward inoculation, no, we can do endoresection and put a wide plaque with low energy seeds, so we can burn any residual tumor cells on the sclera or within the sclera and save the eye, and that's what happened to this patient. So this is the advantage of iodine really over ruthenium. We might say that, yeah, it might be costly, but it gives you more versatility to play with the energy and seed and shape of the radiation to fulfill more needs. Now, some situation, it's better to go straight for EBRT. So this is if the surgery is contraindicated, or if you're unable to do accurate localization of the tumor boundaries because there's significant, you can see in the ultrasound, there is a melanoma there under big retinal detachment with bleeding, or the base is diffuse and wide and hard to tell where it starts and where it ends. You know, these multiclonal melanomas that are dark and go imperceptibly into the choroid. And so this is a relative indication. Might be better to go straight for external beam rather than to put a plaque and miss a part of the tumor. Or if the tumor is encroaching significantly or surrounding completely the nerve with a thick mass, it's maybe better to go for external beam than to put a plaque and miss a significant part of the tumor untreated. We also did a study in situation where there is a recurrence of melanoma after plaque radiotherapy, posterior recurrence. Sometimes it's hard to put a plaque again because of the adhesion, especially if you're working around the oblique muscles. So better in that case, if you want to salvage the globe, is to go for an external beam radiotherapy to treat the recurrence after plaque radiotherapy. And in our study, we had saved 85 eyes almost out of 26 eyes we examined, we re-irradiated from inoculation, and we had to go for a secondary inoculation in 15% of them because they developed radiation complications because they've been treated with radiation twice. So you can use it as an alternative for inoculation in posterior recurrence after plaque radiotherapy. So let me summarize. Brachytherapy provides tumor control rates comparable to teletherapy, but with significantly less radiation-related ocular toxicity. So this is the preferred line of treatment for uveal melanoma. The use of iodine-125 plaques offer customization of the radiation field that can accommodate variable tumor locations and configurations, as I've shown. EBRT may be elected in melanoma surrounding or growing on the optic nerve head or in large juxtapapillary recurrences following plaque brachytherapy. Dose reduction studies, refinement of radiation delivery methods, and perhaps earlier detection and management of radiation toxicities may improve the outcomes generally of radiotherapy of uveal melanoma. And thank you very much.
Thank you, Ratem. Thank you so much for a beautiful presentation. Thank you for joining us today. Carol, I believe you have a second presentation before we go to the questions, right?
All right, can you see my slides?
Yes.
Okay, good. I'd like to talk to you about prophylactic bevacizumab to prevent or delay radiation maculopathy in 1,100 patients. You've heard from Dr. Krema all about melanoma therapy with the nucleation and methods of radiotherapy. Most of us use plaque radiotherapy or proton beam radiotherapy. We can treat melanomas of the choroid, the ciliary body, the iris, extrascleral extension, and if we need to, even repeat plaque radiation. Here you can see a 2.5 millimeter small melanoma before and after plaque radiation showing tumor control, and a large melanoma, 9 millimeters in thickness before and after showing the control. So what's the visual outcome following plaque radiotherapy? Several years ago in Archives of Ophthalmology, we looked at 1,100 consecutive patients, just specifically looking at visual outcome. And we found visual acuity was 2,200 or worse in 68% of patients by 10 years. Terrible visual outcomes. And the risks for poor vision included increased tumor thickness, proximity to the foveola, older patient age, and worse starting vision. But this was before anti-VEGF medications. Now the COMS did a similar study. They looked at 623 patients with medium-sized melanoma, and they found that those patients who had vision better than 2,200 at 3 years had vision worse than 2,200 in 43% of cases, and loss of at least 6 lines was seen in almost 50% of cases. Their conclusion was nearly 50% of treated eyes had substantial impairment in vision by 3 years, again before anti-VEGF medications. So how can we prevent these complications? Well, I've thought long and hard during my career how we can better prevent radiation maculopathy. We have options. We can do mini-sector PRP to the ischemic retina, or give subtenons triamcinolone, or even intravitreal triamcinolone, or give anti-VEGF. So I'm just going to touch on some of the studies that have been done. Maturin et al. Looked at sector laser photocoagulation when he was in our department for treatment of irradiated melanoma. In 29 cases, we had no control group, and we had 3 years results. And you can see here's a patient before treatment, after PRP, and when the PRP had taken. And we found in this trial that we did get some prevention of radiation maculopathy, but it wasn't profound. Then Horgan et al., Horgan's currently chief in Dublin, he looked at periocular triamcinolone for prevention of macular edema after plaque radiotherapy in 163 patients, and found periocular Kenalog given every 4 months for 1 year produced less CME and less vision loss. So we were onto something here. We thought triamcinolone subtenons might be the answer, but it was only a modest impact on vision preservation. Now, Guy Missaten, who's from Belgium, did a very important study published in Archives of Ophthalmology looking at VEGF in eyes with melanoma. He found that normal eyes had VEGF level of 50 picograms per ml. Untreated melanoma had up to 826 picograms, and treated melanomas had up to 3,000 picograms. So the VEGF increases just having a melanoma and treating a melanoma. And if you look at this nice table, here's control eyes with very low VEGF level in the vitreous. And actually he checked it in the aqueous to represent the vitreous. And then if you look at untreated eyes with melanoma, it's slightly elevated, but once you treat the eye, the VEGF level goes up. And even if you add a retinal detachment, the VEGF level's even higher. And then going with treatment, whether it's ruthenium TTT or proton beam, all eyes had elevated VEGF levels, and the highest was seen in proton beam. Hence, when Dr. Krema mentioned proton beam has greater radiation retinopathy, this is probably the reason why there's more ischemia. So Sanket Shah, when he was with us, looked at bevacizumab. Published this in Ophthalmology. We looked at 292 patients. Bevacizumab every 4 months for 7 injections versus controls. And we found at 2 years bevacizumab, Avastin, offered significantly less CME, less maculopathy, and less vision loss. So we gave the bevacizumab at the date of plaque and for every 4 months up to 2 years. Now you should know the peak time to see radiation maculopathy is 12 months, and the peak time to see radiation papillopathy is 18 months in eyes that aren't getting any treatment. So that's why we continued our Avastin up to 2 years. So we would cover those peak times for maculopathy and papillopathy. And we found at 2 years that Avastin versus controls. Avastin had less CME on OCT, less radiation maculopathy, and better vision. Now this study was duplicated up in Boston by the Harvard team with Ivana Kim looking at ranibizumab for prevention of radiation complications. They looked at a small group of 40 patients and they give ranibizumab or Lucentis every 2 months for 2 years, just duplicated our study. And they found similar good results. Ranibizumab had vision better than 2200 at 2 years in 97% of patients, compared to control where only 45% had vision that good. So here's their timeline. They gave every 2 month Lucentis up to 2 years, and they had significantly better outcomes at 2 years in the Lucentis group. So we're on to something. Anti-VEGF can protect vision in eyes that receive radiation. They found vision better than 2200 and better than 2400 or better in significantly greater groups in the Lucentis versus the control. So this is our report that we just published in JAMA Ophthalmology. We looked at bevacizumab every 4 months for 2 years, and we looked at vision at 1, 2, 3, and 4 years out. And we found we gave bevacizumab every 4 months up to 2 years, then stopped. And we looked at visual acuity, radiation maculopathy, and papillopathy at 1, 2, 3, and 4 years. And the comparison found there was significantly difference in outcomes, with bevacizumab having reduced CME, reduced radiation maculopathy, and reduced papillopathy. And how did this translate into vision outcomes? This is where it's really important. Look at the differences. At 1 year, the bevacizumab average visual acuity was 20/40 compared to the control group of 20/60. At 2 years, it was 20/50 versus 2100. Then we stopped bevacizumab, but the impact continued beyond 2 years. Bevacizumab group was 20/60 versus control of 2200. And then at our final outcome at 4 years, bevacizumab was 20/70 mean visual acuity compared to counting fingers in the control group that received nothing. So we really believe that bevacizumab can be one of the answers in protecting visual outcome. We found visual benefit at all 4 endpoints. And now we ask the question, are we finished or should we continue bevacizumab on a Q6-month basis, maybe forever? We don't know, and we're currently investigating this. And there's many other questions to answer. Does age matter, and is there a nomogram to estimate visual outcome? And the answer is yes to both of these. Just look at age. This study done by Michael Chang from our group, he looked at visual outcome following radiotherapy for melanoma based on patient age. It was designed to answer the question, who does better, younger or older patients? And you might think younger patients do better, but on the contrary, younger patients do worse. They have a much more robust VEGF response to ischemia. It was significant for radiation maculopathy. At 4 years, 62% of young patients under the age of 50 had radiation maculopathy compared to 47% of patients over the age of 70 years. And they had significantly more radiation retinopathy. So our conclusion was patients younger than 50 years have an increased 48-month risk of radiation maculopathy following plaque for uveal melanoma. And the last question, is there a nomogram to estimate visual outcome? And the answer is yes. Lauren Dalvin, again, took on this very difficult study where she created a nomogram for visual outcome after radiotherapy of melanoma in 1,100 patients. And you can actually predict the patient visual outcome based on the combination of clinical factors, each factor being assigned a number of points based on visual impact. And this is a very complex topic, and those of you who have an interest in mathematics or statistics will understand this nomogram. The risk for poor vision outcome at 2 years and 4 years increased from 11% and 24% with a low number of points up to 97 to greater than 99% with a high number of points based on these point categories relative to each of the various outcomes. This was a really, really detailed analysis. So those for 2 years and then those for 4 years, the greater the number of points, the worse the vision outcome. So that's a nomogram that can be done, and it can be simplified, so it's very easy to use. So in summary, prophylactic bevacizumab given every 4 months for 2 years has a significant impact on visual outcome in these patients with melanoma treated with radiation at 1 year, at 2 years, and even after you stop the bevacizumab at 3 years and 4 years. Thank you.
Very good, Dr. Shields. Thank you so much. Very exciting that we're going to be able to change visual prognosis of our patients that undergo brachytherapy. That's very exciting.
Rubens, we're going to start with the questions.
Yes, ma'am. Go ahead.
Okay. We have one question for Carol. In a small choroidal melanoma that had 4 or more risk factor, what case do you use only TTT, or it's always a plaque for that?
Okay, that's a good question. When do we use TTT versus plaque? The more risk factors you have, the greater the chance that TTT is going to fail. And this was a study done by Armand Mashiecki in over 350 cases. We found that greater number of risk factors means more active tumor, and that also means greater failure of TTT. So if a patient has 4 or more risk factors, we will likely treat with plaque. Now, if it's a 90-year-old patient or someone who's not going to be a good candidate for plaque treatment, we might start with TTT, especially if it's extramacular, and see if we can achieve control. But in a younger patient or a patient of middle age, we would go right on to plaque.
Very good, Carol. Thank you. So there was a question of the Ruthenium Plaque price. I did answer that because I'm not sure if that's available in the States. It's about 18,000 euros for a plaque that lasts for about 1 year. So.
There is another question that what are the adverse effects for teletherapy in neighbor tissues? Maybe you talked something.
Oh, yeah, it's the same thing, radiation retinopathy, radiation papillopathy, depends on, it's just like the energy is not focused to the tumor alone and spares the tissues as the case with plaques. Plaques, the energy is more focused. So more likelihood to develop the same complications, Also, we noticed recently, and I'm not sure about that, like I've noticed patients who've been treated with external beam, they develop some sort of scleritis. Few months after treatment, they develop sometimes severe excruciating pain when you see the T sign in ultrasound, like scleritis-like, posterior scleritis-like picture. And I was in a meeting in Europe, and they mentioned the same thing about proton beam, and they attributed to the tangent clips. They called it clip scleritis. But we do not use the clip with the stereotactic with external beam. So I think it's related maybe to ischemia of the sclera, significant ischemia to the sclera that produces this. I did not see that with plaques before, but that's exclusive to the external beam. Otherwise, the same complications happen with brachytherapy and teletherapy are the same, just they are more common with teletherapy.
Thank you, Hatem. So we have a question from Basil, Dr. Williams. He's been involved with Pan American with Melina, Solon, David, who's also here. So Carol, how did you decide to treat every 4 months? And do you think it would be beneficial to inject more frequently after brachytherapy?
Yeah, good question. That was based on the practicality of getting our patients back into our clinic. So generally when we see patients, we will do their plaque and we see them 4 months later for follow-up. And we generally follow them every 4 months, at least the first year. So we thought it would be most practical just to call them back when we normally see them rather than bringing them back every 2 months. I suspect if we had a patient from Philadelphia who really wanted to be uptight about anti-VEGF, we could do it every 2 months, but every 4 months was most convenient.
Okay.
And Rubens, there is another one for Dr. Shield. Any old-based models for nevus to melanoma screening?
Artificial intelligence based models for nevi/melanoma screening. Do you have any information?
Wonderful question. That's a wonderful question, and it's very relevant. So now that we have all of this imaging, and we know risk factors, and we know percent transformation in 5 years, this is a segue into artificial intelligence. So right now, I'm working with the FDA and the American Academy of Ophthalmology, and we're working on artificial intelligence, and Google's also involved, where we're going to try to use imaging. First, we have to teach the computer to recognize nevus versus normal fundus, and then teach the computer to recognize the various imaging findings of orange pigment on autofluorescence, SRF on, it's not going to always be right, but you can get a very highly reliable artificial intelligence interpretation just by teaching computers. So yeah, that's relevant. And for any of you interested, there's going to be an artificial intelligence meeting at the FDA for glaucoma, for retina. Glaucoma is Joel Schumann from NYU. Retina is going to be headed by Emily Chu at the NIH. Ocular Oncology will be headed by me with a lot of speakers from around the world. And it's going to be on choroidal nevus transformation into melanoma. And there's going to be a few other sections too. And this is going to be September 3rd and 4th. It's a Thursday and a Friday, and it'll be for free. It's a free webinar on artificial intelligence.
Good.
They're going to post it online.
Good. Thank you. A question from Aditya. How important is the acoustic hollowness as a risk factor to decide for treatment in choroidal indeterminate and melanocytic lesions? Would you say choroidal hollowness is more important than the other risk factors?
So the 3 most important risk factors are thickness, fluid, and orange pigment. So hollowness is like number 4 or 5 in the importance list. So if we see a patient who has what looks like a hollow nevus and it measures maybe 2.1 millimeters in thickness and no other features, we'll just watch that. And watch it maybe in 4 months and then every 6 months. So it doesn't prompt us to jump into treatment right away.
Okay, there is another one question for you, Carol. When do you indicate a biopsy in a melanocytic lesion?
So the question is, when should we do a biopsy, a fine needle aspiration biopsy on a melanocytic lesion? Well, we offer biopsy for all melanomas, looking at the cytogenetics of the melanomas. Some people do it for cytology and cytogenetics. We generally just do it for cytogenetics. We want to minimize the number of needles we stick in the eye. And for nevi, if we're not sure, say it shows a little bit of growth or some suspicious features and the patient's uncomfortable with watching, we'll do a needle biopsy for cytology and cytogenetics. And if cytogenetics is negative, then we know it's a very low risk lesion and we have time if we want to watch it.
Very good, thank you. So have you observed a difference between posterior pole melanoma and peripheral melanomas regarding radiation retinopathy, Carol?
Yeah, I think Hatem knows this too. Those patients that we treat with peripheral melanomas near the ciliary body show much less radiation retinopathy. So radiation retinopathy is directly correlated to the tumor thickness and the number of millimeters you are from the foveola. The further you are, the better you are.
Do you have any evidence of intrabeam in the treatment for uveal choroidal melanoma?
What was the question? Do you have any interest?
Any evidence
of
intrabeam in the treatment for uveal choroidal melanoma?
I didn't get that one word. Intrabeam?
Intrabeam?
Intravenous?
No, well, yeah, the question is if you have evidence of intrabeam. I don't know if that's a commercially.
Maybe Dr. Krema knows about that?
Yeah.
I don't know what's intrabeam.
Okay, so if you, Juan, if you could please rephrase your question so we better understand.
Juan Manuel Trejo.
Okay. Well, let's move to the next question. What's your opinion on combining thermotherapy and ruthenium as an effective for tumors over 7 millimeters in height? Maybe Ratem, you'd like to answer this one?
Yeah, so that was used in the countries where they had to use ruthenium. What they call the sandwich technique is you put the plaque up to a height of 5-6 millimeter, and the extra 2 or 3 millimeter at the apex you hit with TTT. And I think it was reasonably well, and I did that and at a certain stage of my life when I did not have iodine. Having said that, and probably Dr. Shields can say, like, TTT is really a light treatment. You need something that goes and breaks DNA of the tumor cells. TTT, the way it works, we don't know exactly how it works. Some people say it changes the pH of the environment, so that's not good for the tumor cells. Sometimes it's just thermal ablation of the tumor and the retina on top of it. So it's not really a reliable treatment for tumors. But anyway, like, yeah, some people in the past, and including myself, we used it for tumors like 7-8 millimeter to do the sandwich ruthenium, plus a session or 2 sessions of TTT after.
Very good, thank you, Ratem. So, okay, the next question comes from Mexico. David Ancona is asking Dr. Krema, your personal preference of stereotactic radiosurgery for choroidal melanoma and why, either gamma knife or cyber knife. And also he wants to know what's your ideal patient to treat with stereotactic radiosurgery.
Okay, so my preference is to use Plux. Number 2 is Plux. Number 3, if I'm gonna use between the teletherapy, it's proton beam. Cyber knife and stereotactic, like the photon, the one that rotates, the VNet that rotates, are exactly the same. The indications, as I say, when I'm gonna choose an external beam over plaque is that if there is a contraindication to put the patient under general anesthesia to insert a plaque, or there is a tumor encroaching significantly on the optic nerve that it's hard to put a plaque to cover the entire thing, or there is recurrence posteriorly at the nerve and it's hard to replaque in that area because of the adhesions, and you have muscles and you're not sure that you're gonna cover it well. Like, you can replaque obviously, but sometimes it's difficult when it's around the nerve and there's lots of adhesions, so you can go straight for external beam radiotherapy. So these are the indications when I choose radiotherapy, external beam over plaque.
Okay, very good. So another question for you, Hatem. When the lesion is ahead, I would say anterior to the equator, do you prefer brachytherapy or EBRT?
definitely brachy, like the radiation oncologist will not treat a tumor in the ciliary body with external beam because they know that this dose can perforate the cornea. And in the past, we had an incident like that. Proton beam might be better because, as I say, the energy is kind of delivered at the tumor without causing much damage to the tissues around, but still, definitely plaque would be superior to external beam for anterior tumors.
Okay.
There is another question for Carol. Are you using TTT in all the melanoma that use plaque?
Oh, that's a good question. So we used to like to consolidate. Every melanoma that we treated with radiation, we would consolidate with TTT. And we still do like what Dr. Krema said. If it's close to the nerve, we might want to consolidate just to be sure that margin near the nerve is completely wiped out. But we don't necessarily consolidate all melanomas with TTT. Those that have persistent subretinal fluid, of course, we would not consolidate because we worry about perforating the retina. And those that are like really big, we wouldn't see the reason for using consolidation with TTT. It's nice to consolidate with TTT because it really ensures that your scar is completely wiped out. And some people feel it gets rid of some of the residual VEGF that still leaks out of the necrotic tumor if you TTT and you just get rid of it. So in answer to that question, in some cases we do, but not in all cases.
Very good. Thank you, Kara. I believe we've addressed all questions. Before Dr. Alarcon closes the meeting, I'd like to ask you guys for a quick favor. If you could please turn on your cameras and give us a big smile so we can take a print screen since we cannot take a selfie. And that way we'll send the print screen to friends and colleagues. I see Maria Manques from Chile. I see Basil. It's a nice, we see so many fellows from Brazil. And Davi is here. So if you could just smile.
Rubens, I think.
Okay, no, I took my picture. Go back. Do you have another question?
No, I didn't see all the people in my screen.
Well, yeah, we have 140 participants now. We had as many as 205 at a certain point during the presentation. So very good, very successful. And Dr. Krema, Dr. Shields would like to address the crowd for any final comment.
I need to address you, Ruben. How many countries have the brachytherapy lab? Like you have the facility to do plaque radiotherapy? Do you know?
In Latin America, well, in Argentina, in Brazil, I believe in Chile. Maria Manques, please move your head to concur. I believe in Chile they have brachytherapy as well. In Central America, I know Mexico does. Davi, any other countries in Central America offer brachytherapy?
Venezuela, they said.
Venezuela, okay.
And in this you use iodine or ruthenium, just let me know.
Both in Brazil. Arturo was here. I'm not sure. I know they have a ruthenium in Argentina. I'm not sure. Lucia, do you have iodine as well?
So as I mentioned, becoming the standard care for most of intraocular tumors and some of extraocular. Maybe in the future I'll give you a talk about radiotherapy for extraocular tumors and applications of plaque. I think it's important for Latin America to have more than this, more brachytherapy labs. Like I get very smart fellows trained from Latin America and they get disappointed when they go back to their countries and they have to inoculate a melanoma that could be treated with a plaque. So it's actually people like yourself and Solon and Miguel, like the people who have some maybe power in their countries to find a way to have more brachytherapy labs around, and so that maybe reduce and find a way to transfer it quickly to the ocular oncologists around, like create protocols so it can pass through the airports with ease after the COVID-19 situation ends. So hopefully you can have more of that because, as I say, like I'm sure there are lots of patients in needs and the applications are vast. And that's the essence really of treating most of the intraocular tumors now, not the external beam radiotherapy. As I mentioned, like iodine flux in particular is superior to any other form of brachytherapy. It just needs to be available. And my group, radiation oncologists, physicists, radiation medicine, myself, we're ready to support by any way, logistics, training, anything you like, just be in touch with us. And from Canada, we're ready to help in any way to establish radiation brachytherapy labs in any country. So hopefully you consider that in the near future.
It is a very important problem, and unfortunately, most of our patients cannot afford, since it's not widely available in the public system. That's the big problem in Brazil. The rich patients can afford it, and the poor patients don't get to.
But when it's nearby, it's not as expensive as it seems. Like when it's around you, then getting it, and you have the expertise, the people who are doing the calculations for you, if they are in-house, it's going to be much cheaper.
I totally agree. It's just government stupidity. It's not a matter of the cost, because brachytherapy is not that expensive. It's not that expensive, and we know that. And all the Latin Americans are doing that, are agreeing, because you know it's not the cost. It's just not being available because the government doesn't organize public health in an ideal way. It's not the cost. I totally agree. Those machines you've shown, we have those available in Latin America, and they're a number of times more expensive than having a plaque available, especially if you take ruthenium for you know, the example.
All right, it was a pleasure to meet with you all. I hope we talk again in the future.
Okay, we just finished the presentations. We really appreciate the participation of Dr. Carol and Dr. Krema. As always, with excellent presentations that help us with the management of the patients. Thank you very much for your participation. And second, I want to say thanks to Dr. Salom to invite me to be a moderator in these presentations.
Thank you all.
Thank you. Stay safe. Bye-bye.
Okay, bye.
Thank you.
Gracias, Solon. Thank you, Carol. Thank you, Melina. Ratem, thank you so much. See you guys soon. Bye-bye. Gracias.
Solon, un abrazo. Rubens, un abrazo. Carolina, muchas gracias.
Chao, gracias.
Thank you, doctora Carol. Thank you, doctor.
Gran placer. Muchas gracias.
Gracias.
Daniel, qué buen verte en Argentina, mi amigo.
Un abrazo, Rubensinho.
Un beso grande.
Daniel.
Bueno,
Mucho
gracias,
placer,
maestro.
Solón.
Gracias por acompañarnos, Daniel.
A todos, siempre. Es un placer.
Gracias
Gracias,
a todos.
maestro.
Chao, gente. Chao.
Cuídense.
Igualmente para ustedes.